You're listening to Medscape's In Discussion series on cardiorenal metabolic syndrome, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Nihar Desai. Dr. Desai is an associate professor of medicine and vice chief of the section of cardiovascular medicine at Yale University School of Medicine. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Nihar Desai from the Yale School of Medicine. Welcome to Season 1 of the Medscape In Discussion Cardiorenal Metabolic Syndrome podcast series. Today, we're discussing obesity therapies within the context of the cardiorenal metabolic syndrome. I'm absolutely delighted to have as our guest today, Dr. Neda Rasouli. Dr. Rasouli is an endocrinologist, professor of medicine, and director of diabetes and endocrinology clinical trials at the University of Colorado School of Medicine. Neda, welcome to the Medscape In Discussion podcast.
Thank you, Dr. Desai, for the great introduction. I'm delighted to be here and looking forward to a great discussion.
Well, thanks so much. I'm incredibly excited to have you. There's so much happening in this space. There's so many therapies and so many trials. And I know everyone is hearing about these therapies in their own practice. And so couldn't have asked for a better person, a better expert to kind of take us through and bring us up to speed. So maybe we'll start and actually go back to the American Heart Association CKM syndrome statement, that was put out. And I think one of the very important elements of that statement was that the whole cardiovascular kidney metabolic syndrome begins with dysfunctional adipose tissue. And we know then about the interrelated mechanisms and the downstream effects of that dysfunctional adipose tissue on the cardiovascular system, on the kidneys, on the pancreas, on insulin resistance and dyslipidemia, all of the constellation of features that we think of as part and parcel of the CKM syndrome. And so with obesity really as a starting point and part of the linchpin of CKM syndrome, Neda, I was wondering if maybe you could tell us a little bit about what's happening to the prevalence of obesity. What are the latest numbers that we have, and what has happened over time to obesity rates in the US?
Yeah, the prevalence of obesity is increasing. In the past decade, unfortunately, we see a consistent rise in the prevalence of obesity. Currently, about 40% of adults in the US are considered obese based on BMI definition more than 30. And even the sadder news is increased prevalence of obesity among children. 1 out of 5 child in the US between age 2 to 19 are considered obese. In addition to obesity, we have problem with overweight. 30% of people in the US are also overweight. So if you add up obesity and overweight together, we are left with only 30% of the people in normal weight. So now normal weight has been a minority. Unfortunately, this number is going to rise based on prediction by 2030. In just few years, we have half of the population in the US considered obese. So more than 50% are obese. And obesity is affecting more underrepresented minority than others, like non-Hispanic Black adults or low-income adults are more susceptible to obesity. These are the same population that are at risk for other metabolic diseases, cardiovascular disease, or kidney disease.
Wow, so we're talking about, 2/3, maybe 3/4 of the population as qualifying as overweight or obese, again, just based on, kind of standard criteria. And if anything, those numbers are likely to increase over time. And so I'm sure everyone's experience is similar to mine that sadly, most of the patients that we are caring for, whether that's in the office or in the hospital or another care setting, seem to have either overweight or obesity. But that really brings into very clear focus then the importance of the therapies that we're talking about, some of the new and novel things that we have to offer to patients and why that this is such an important concept. As someone who does this and has deep expertise in obesity and obesity medicine, what's your approach at a high level? What should the provider, the practitioner be aware of? Because they're going to get questions from their patients. And so, how should you or how can you help counsel us about how to think about obesity just from a conceptual standpoint?
Topic per se requires probably hours of lectures. But if I want to just talk about high level, the simple answer is obesity affects all hormones in the body. So it's not as simple as we think that there is just one single hormone abnormality that causing obesity, or obesity results in one or two hormone abnormalities. Overall, obesity is a complex disease and involves excess fat depot. We know that as a fact. And there are so many hormonal abnormality associated with obesity. But I want to focus on some of the hormones that are related to appetite regulation. And mainly, I will mention at least two of them that everybody should be familiar. One is ghrelin, second, leptin. And what are these hormones? We know that interaction between ghrelin and leptin are important in sensation of hunger and satiety, and they both regulate appetite. Ghrelin is also known as hunger hormone. Is released by stomach when the stomach is empty, and it sends signal to brain to eat. Ghrelin level usually goes up before eating or when we are fasting, and it regulates metabolism, insulin, and glucagon secretion, and also have some cardiovascular effect. Leptin, in contrast, is called satiety hormone. So leptin is produced by fat cells, and it sends signal to brain that you're full. Stop eating. Obesity usually is associated with some degree of leptin resistance. So even if we have increased fat tissue and increased levels of leptin in the circulation, the effect of leptin is diminished, and we don't have, as you see in obesity, the level of satiety is low and people don't feel full. Leptin signaling also at the end in the hypothalamus activate a receptor that we should all know about, that melanocortin 4 receptors. That activation of this receptor is very important in our satiety and appetite regulation. We learn all of this from rare cases of obesity. There are people that they have mutation in, for example, leptin receptor or in melanocortin 4 receptors. This mutation in these single genes are associated with hyperphagia, childhood obesity, severe obesity, and we are talking about monogenic obesity in these cases. But these rare cases taught us what molecules or what receptors are very important in pathophysiology of obesity. And in fact, we have therapies that in this rare case of obesity, when people have mutation in leptin receptor in hypothalamus, or they have one of those peptides in the signaling pathway of leptin or melanocortin 4 receptors impairment, by activation of this melanocortin receptor through pharmacotherapy, we can improve hyperphagia, we can treat obesity in the monogenic forms again. In general obesity, typically these medication are not indicated or work, but have taught us that leptin, melanocortin 4, like PCK1, or these are the signalings that are important in the pathway of appetite regulations. So we talked briefly about appetite hormone, but the other set of hormones that are important are hormones coming from adipose tissues. And these are the ones that are associated with insulin resistance, or the cause of insulin resistance, also associated with increased risk of ASCVD. And namely, we can say all of these interleukin, TNF, or decreased level of adipokines that has anti-inflammatory effect. All hormones are affected by obesity, but the main one that I will focus is appetite regulating hormone and hormone coming from adipose tissue that can have different consequences on metabolism and also ASCVD.
Thanks so much. I mean, that it's so helpful to go through that and to hear that from obviously someone who has incredible expertise in this area. But I think just giving our audience a sense of what are some of the key pathways, what are some of the key hormones, and to your point, that our scientific understanding of obesity and the mechanisms of obesity has improved so substantially. And now we're also starting to see on the complementary side more and more therapies. And so I want to shift and kind of get into that side of the story now in terms of management of obesity or options to treat obesity. And before we get into the pharmacotherapies, the drugs, which I know there's been such an explosion of therapies on that side, I was hoping that you could tell the audience a little bit about surgical intervention for obesity. So, give us a little history on bariatric surgery, the surgical management of obesity. What was the impact on weight loss with that type of intervention? And what else did we learn about in terms of diabetes control or blood pressure control and maybe even cardiovascular events?
Okay, so about bariatric surgery. Bariatric surgery have been the most effective intervention for management of obesity for many years now. I mean, of course, it has its own potential complications and morbidity associated with this kind of invasive intervention, but they are very effective. Let's kind of give a brief background on types of bariatric surgery to our audience. I start with the most effective to the least effective type of surgery. The first one is gastric bypass. And in this procedure, they remove part of the stomach and also a small intestine. They bypass that area, which result in reduction of the food absorption and also interfere with some of the hormone released by GI system. The other one is sleeve gastrectomy. In this procedure, they remove most of the stomach. And also, as I mentioned, ghrelin is one of the hormones that mainly come from stomach. It reduces ghrelin level and decreases the volume of the stomach so people can eat less. The third one is least invasive, but at the same time least effective in regard to weight loss is laparoscopic gastric banding. And in this procedure, usually a band is placed around the top of the stomach to reduce the size of the opening, and therefore the food intake goes down. So these procedures usually cause something between 15 to 25% weight loss. A lot of people maintain this weight loss, but there is a group of people that they can regain the weight after many years. The problem with this kind of regain is, I mean, all of the metabolic consequences of obesity might come back. We see a lot of improvement when the weight loss has happened or weight loss is maintained. So you specifically ask about diabetes, hypertension, or ASCVD. In a very recent meta-analysis of the bariatric surgery, multiple studies that they have followed patients for many years, it has shown that the risk of ASCVD, including coronary artery disease, MI, heart failure, stroke, they have all decreased by about 20-30% in average. AFib was the one that, at least in this specific meta-analysis, the risk was not changed, but other cardiovascular morbidity or mortality reduced after bariatric surgery. And then we have so many studies in regard to diabetes or hypertension. Bariatric surgery improved all of them.
Maybe just for the rest of our discussion, we'll sort of keep some of those numbers, front of mind. So I think, Neda, you said for bariatric surgery, you're thinking about almost a 25% reduction in body weight, kind of for the most extensive surgical intervention, the most potent effect on weight loss is something on the order of 25%. And so I think for the audience, it'll be helpful as we think now about the pharmacotherapy. How do those therapies stack up relative to where we have gotten with bariatric surgery? And so maybe we'll sort of go there now in our discussion. And for the audience, I think the history here is so important, and there's and rightfully so, so much excitement about, semaglutide and tirzepatide and other, more of the novel therapies. But can you very quickly maybe tell us about some of the older therapies that we had?
I would say I start with this statement that to have a meaningful clinical benefit of weight loss, we need at least 10% weight loss. And in our first generation of the anti obesity medication, we barely hit that 10%. Let's talk about what we had. We had phentermine, that is a sympathomimetic adrenergic agent. It caused about 5% weight loss, and it has side effects of palpitation. It's contraindicated in people with coronary artery disease, and people can use it only for a short term, up to 3 months is approved. Then we had orlistat, is a GI lipase inhibitor. So it blocks absorption of fat. Therefore, it causes about 5% weight loss. Again, we are at the range of 5%. But because of the malabsorption that it causes, especially with a high fat content food, it is associated with a lot of GI symptoms, and people cannot tolerate it. Then we had this extended release phentermine with topiramate. Topiramate is a anti-seizure medication. Combination with phentermine and topiramate with the brand name of Qsimia cause up to 10% weight loss. So this is the first medication we are seeing about 10% weight loss. But again, it had insomnia, increased heart rate because of phentermine, and it had a lot of risk for causing birth defect. Therefore, in childbearing age is not safe, and people need to do a frequent pregnancy test. The last was naltrexone bupropion with the brand name of Contrave. The naltrexone has opioid antagonism. Bupropion is kind of used for a smoking cessation. And this medication has shown that it decreased craving for food, but the weight loss was only 5%. So none of these first generation were that effective. And then we came up with this new generation of GLP-1 receptor agonists that I can talk later about them.
Some of the older therapies, not only were there unappealing side effects or things that really impaired adherence or long term use of the therapies, but even on the efficacy side, to your point, if you're only seeing, maybe 5% or somewhere between 5 and 10%, weight loss, that's just not enough in terms of a meaningful reduction in body weight to get the improvements in metabolic, cardiovascular, kidney, and metabolic, sort of outcomes. So let's kind of get to where, I think all the enthusiasm and all the excitement is in the field, which is to the newer class of therapies and the newer generation of therapies. And so think about semaglutide and tirzepatide maybe, and maybe we'll start with those two specifically. And so Neda, can you tell us a little bit again about what's the mechanism of these two different therapies? What kind of weight loss are we seeing? And then what else have we learned about them in terms of cardiovascular outcomes?
Semaglutide is a long-acting GLP-1 receptor agonist. Because of that GLP-1 activity, it suppresses appetite, it decreases gastric motility, it also stimulates insulin secretion, suppress glucagon. Through all of this mechanism, originally it was approved for treatment of diabetes because of glucose lowering effect. But it also, as a very welcoming side effect, was the weight loss of it. And in people who had diabetes, it usually caused about, in average from trial, about 10% weight loss. But it's more exciting in people who do not have diabetes. It causes even more weight loss of up to 15%. The side effect of it is mainly GI symptoms. People have nausea, some people even more severe form like vomiting, gas, distension, diarrhea, constipation. But typically these symptoms goes away, and with titration, slow titration, the symptom becomes more tolerable. Then the second generation is tirzepatide, which is dual agonist. Both GLP-1 and GIP, both of are incretin hormone released by a small intestine. And this dual agonism of two different receptor has been even more efficacious in weight loss. With terzepatide, we see 15 to 20% weight loss. So we are now getting closer to bariatric surgery intervention weight loss effect. And this medication or terzepatide is both approved for diabetes management, so it has glucose lowering effect, and also for weight loss.
Neda, can you tell us a little bit about some of the other, outcomes or what else we've learned about these therapies in terms of kidney protection or cardiovascular event protection, maybe at a high level, beyond the primary effect, if you will, on weight loss or weight reduction. Well, what else have we learned about these therapies that might be relevant to our audience?
Yeah, semaglutide was approved a couple of years before tirzepatide. Therefore, they are ahead in regard to trials showing effect on cardiovascular benefit or kidney benefit. So I summarize briefly. We have semaglutide showing reduction in MACE or major adverse cardiovascular event in people with diabetes, and also it has been shown in people without diabetes and only obese through select trial that semaglutide can reduce MACE. Tirzepatide, we don't have this evidence yet, but studies are ongoing. We have SURPASS CVOT and we have SERMANT MMO showing effect of tirzepatide in regard to cardiovascular event in people with diabetes and non-diabetic obese people. Semaglutide has data on kidney protection through FLOW trial that was recently published that semaglutide can reduce the risk of kidney composite outcome overall. Tirzepatide, again, data is pending, so we know that semaglutide can protect people from progression of kidney disease. We have data on both semaglutide and tirzepatide on heart failure. We know HFpEF is a common problem and comorbidity of obesity. We have semaglutide data showing reduction of HFpEF symptoms, also tirzepatide reducing the rate of hospitalization for heart failure.
What are you most excited about? What's the future of the medical therapy for obesity? And what is someone who is an expert in this area and deeply involved in evidence generation and clinical trials? What are you most looking forward to? And, what do you think the audience should be paying attention to going forward?
I think we are in a very exciting time for treatment and management of obesity and all the metabolic consequences of obesity. We have newer medication in pipeline. The most exciting one is the triple G agonist, which stand for GLP-1, GIP, and glucagon receptor agonist with the name of retatrutide. We have phase 2 trials showing weight loss up to 25%. So again, we are getting close to bariatric surgery effect. So if we find pharmacotherapy or medical therapy for obesity that are effective, look like our preliminary data showing significant efficacy in weight loss, they are durable, and they are affordable. These are the three things I will say it's important for a pharmacotherapy of the obesity. And if look like our science has advanced so much that we have new compound with a great efficacy. Tolerability still is a question because there are a subgroup of people that they cannot tolerate this medication. And we haven't gone through the problem of weight loss and frailty because with weight loss, there is always some muscle loss associated. When you lose weight, about two-thirds of weight loss is fat loss and one-third muscle loss. I won't see any problem with the weight loss and muscle loss that much, but the problem starts when these people gain back weight and they stop medication, and then they have lost significant amount of muscle, and when they gain back is all fat. Tolerability, I touched base, but affordability. I think if we cannot use this medication in majority of our people that need it because of the high cost, then we haven't used our scientific advances. So I'm super excited about the future of obesity. We have effective medication. Hopefully, at some point in future, that like discovery of penicillin that helped us to get rid of mortality after infection. With this newer pharmacotherapy, will eliminate obesity or at least slow down the rate of growth, increase in the prevalence of obesity.
Well, thanks so much, Neda. What a terrific discussion. I mean, we covered so much here around mechanisms of obesity, prevalence, where we are in terms of surgical approaches, and then, of course, all the pharmacotherapies. And you even gave us kind of a look forward or a look ahead for some of the newer and most novel therapies that are being developed in this front. Certainly, lots of excitement. This was a terrific discussion. I so very much appreciate you kind of joining this podcast discussion, and I'm sure the audience appreciated it as well. I'll just say again to please take a moment to download the Medscape app to listen and subscribe to this podcast series. Thanks again for joining us, Neda. This is Nihar Desai from the Yale School of Medicine for the Medscape in Discussion Cardiorenal Metabolic Syndrome podcast series.
Thanks for listening to Medscape's In Discussion Cardiorenal Metabolic Syndrome podcast series with our host, Dr. Nihar Desai. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on cardiorenal metabolic syndrome.